They did professional ground up work with the right stakeholders.
Yeah.
And I would argue for us, it's understanding what does everybody else think about that controls the dollars and controls the policy. Those are often the same. What are they thinking about? What's in their mind? And how do we tap into that? And like the data's out there. I would argue we're not using it.
Kick it.
Welcome to Strata Stories. My name is Thomas Schreiber, and I'm the Director of Marketing here at Strata PT. Strata PT is a single EMR platform and revenue cycle management service for physical, occupational, and speech therapy practices that helps you achieve a 99.99% reimbursement rate. On today's episode, Paul Singh, the CEO of Strata PT, talks with Dana Strauss, who is a PT and the Senior Director of Government Affairs at CVS Health. Paul and Dana discuss the real reason prior authorizations exist and how to adapt, lessons from optometrists, podiatrists to change public perspective, how to get doctors to think therapy first, and lastly, using data to prove therapy's value and win over payers. If you'd like to learn more about Strata PT and see how our EMR and RCM works, head over to stratapt.com to book a demo. Now, without further delay, here's today's episode.
In your latest email to me, you said something along the lines of like, 3% pay cut last year, reimbursement cut last year. It's trending towards 0% cut this year if it gets approved as is. And then you went on to like call it out and say, but even then, it's probably a loss. It's a loss as well when you tie in RVUs and everything else. Maybe like the first question I'd ask you is like, here we are in October of 2024. Is it basically is it worth even fighting to fix this or improve it this close to the end of the year? Or is it like kind of just prepare for it and let's make a game plan as an industry for 2025? How do you think about that?
So the physician fee schedule, when therapists talk about it, I'm trying to shift the way they think about it to think about it from the lens of how policymakers look at the physician fee schedule and the budget. Because as is natural for everybody, we get into our own silos. And it just seems to me, as I'm reading on LinkedIn and kind of looking at what the advocacy looks like, we're fighting for a conversion factor fix and an inflationary update, right? But the conversion factor keeps being cut, which is expected because we're blowing out the budget. And by we, I mean everyone that bills the physician fee schedule. That's anybody in outpatient that bills, and we're talking Medicare here. But Medicare Part B, and this is happening with other payers too. There's a budget, they blow through it. In order to pay everybody, they have to cut the conversion factor. But that's not the only thing that's adjusted. So every year when they make the conversion factor change, they also look at every specialist, and that includes therapists. They look at all of their codes and they reallocate weights so it's conversion factor times the weight of the code used by that specialist. And that's why you can see a conversion factor cut, but say internal medicine and behavioral health gets a 3 to 4% raise because it's the combination of conversion factor and the weight of their codes. And so physicians, specialists, specialty physicians, they're putting the hard work into addressing like an inflationary update, something comparable to inpatient settings. I think that there's other places we could be putting effort as therapists. Things like the value of the weight of our codes could be higher. And again, I know I've repeated this theme, but behavioral health providers have knocked it out of the ballpark here, right? Trying to demonstrate that our value as therapists, behavioral health providers, and physicians and APPs together manage patients longitudinally, and our value in this team and primary care is keeping people out of the hospital, keeping people home, reducing total cost of care, reducing high cost specialty care. And that we have not translated that as a profession. That's the missing link. We can't control the conversion factor issue. We can't control the inflationary index. And these are tens of billions of dollars to change to add an inflationary update. That money has to come from somewhere, and it's going to be a lot of hard work to find it. But what we do, like your locus of control, what we can control, trying to look from the lens of how policymakers and regulators, how they're looking at spend and the value behind those dollars. who they're hearing from, right?
There's research behind this idea that the more experienced somebody is in a particular industry, the more likely they are to feel comfortable saying, I don't know. And I
Yeah.
feel like you're displaying that right now because you probably take this stuff for granted. But talk to me like a second grader here, for example. Like, you I think what you're alluding to is this idea that if we had the data to somehow tie the outpatient PT world's efforts to some sort of better outcomes for people
Yeah.
or for patients, that's basically what you're saying, right? You're like, if you had the data to show that, which I think implicitly we could agree that it's probably there. What does that data look like? So, and talk to me like a second grader, and you can talk to the audience like a second grader here for a second.
Yeah.
Like, if we were to go out and survey 100 outpatient clinics, so pick a number, right? 100,000, whatever. What's the question that we should be asking them? Or what is the question they should be asking of their own data to be able to provide that? Like, what does that look like?
Because it's easier for me to frame it this way, let me back into that by telling you a little bit about what physicians show when they're trying to show their value in
Yes.
contracting. Okay.
Awesome. Yes.
So physicians that are looking to get into relationships where they're rewarded for reducing total cost of care over the year, they're looking at data points such as they're buying data usually from a VDRC, which it's an acronym, I forgot what it stands for, but it's a total complete Medicare file of all Medicare claims for like 4 years in the past. Don't quote me, but approximately. And then they're looking at, so their analytics provider is looking at how they've managed patients to prevent hospitalizations, ER visits, what diagnoses are leading to hospitalizations, right? What risk level of patients combined with chronic conditions is leading to hospitalizations. They're looking at their referrals to specialists, their volumes of referrals. They're looking at the outcomes of the specialists they refer to. They're looking at the utilization of other inpatient sites of care, of imaging. All these high cost things are the things that the physician fee schedule is spending money on, and other parts of Medicare are spending money on, right? If you're thinking, again, Medicare is the biggest insurer, CMS, Medicare and Medicaid. It's all inpatient care, specialty physicians, specialty physician intervention, imaging, and like that's where the spend is. So what you have like policymakers thinking about is we have these mammoth amount of spend. Now, how do we get control of it? And when primary care is looking to come into a relationship with a payer, they want to ideally demonstrate that they're improving the metrics that contribute to spend, right? So you want to be able to show compared to the average in your region, and you can look at a whole bunch of different ways to stratify the data. You want to be able to say that our practice in totality, even you can do it by provider themselves, we are, compared to our competitors, contributing more to controlling costs or reducing spend, reducing hospitalizations, right? You want to prove that because that then demonstrates that you will help that payer spend less money, and all of these things translate to better care, right? If you're keeping people out of the hospital and you're keeping them within the primary care setting, you're going to reduce spend and it's better for them. So it's like this easy combination of better interactions, better like units, things like imaging and specialists, those types of things are controlled by primary care better. And then the spend for the payers better. So those are the typical metrics physicians will look at when they're getting into contracts.
Okay. As you can figure out pretty quickly, I have no problem looking like the idiot here. But this is like the way I approached a lot of the other industries I got involved in, venture capital, everything else, right? So let me ask a question here. The way you just described that, I guess when I asked that question, I assumed that what would be needed is for a group of small outpatient PT practices to somehow sign a bunch of BAAs such that we could all share the data about our individual patient population, blah, blah, blah. It just seems that that was the only way to abstract it. But I think what you just said is that we let me just stop beating around the bush. What you just described basically appears to not require the agreement of 50 or 100 practice owners to share data. It sounds like it requires one financial sponsor to buy the data from these VDRCs and essentially sponsor the analytics around that data and figure out how to tell a story. In other words, what you just said there sort of says you don't need 100 practice owners to agree to share data. You just need
No,
one person to be willing to stick their neck out and
that's
buy
right.
the data. Is that fair? You're nodding. Okay. That's wild.
No, it's fair. And it's when it comes to therapy, the backing into it part, I would think about it first as I don't know what you're going to find. So you would want to come at it maybe with an open mind that we're going to have to see what we find in the data and then really, think hard about everything that you as a practice or a group of practices or whatever, all of the things that you either believe strongly or know, or some combination, you have a sense that you're impacting in terms of patient quality, patient spend, right? Think about what those things could be. And then you're going to work with the data vendor to try to stratify and hopefully prove that those things are true. So you can look at patients who've had, let's say, low back pain diagnosis. They've had in a PT evaluation in your clinic. And then you're going to compare, like for just as an example, you're going to compare a patient who never had an MRI or a primary care visit or an X-ray or a specialist, whatever. You're going to compare the spend between if they just had PT through 3 or 6 months after, let's say, to a patient who had a different trajectory, which can be 10 times the cost, right? And then you're going to try to demonstrate, and I think the data would be there to say when my beneficiaries, when my patients have this trajectory, you're the payer, this is their trajectory. Look at the difference in spend and outcomes when they had PT first versus when they saw the physician and the specialist and had imaging and had surgery. And you're going to look for those patterns to try to demonstrate your value. You're being very heavily undervalued by the payer for the outcomes you are getting them. That's the disconnect that therapists have. We've not made that connection, that that's what they care about.
Yeah.
Does that make sense?
It totally does. And my sort of layman's summary of it is that I remember when I was starting my first venture capital fund, I didn't know what I didn't know. And I just thought it was this abstract, weird thing. And I don't know, I just thought you like herd a bunch of cats and you somehow get around like a closing table and magically.
Yeah.
And I remember finally, like, there was probably this one attorney, Josh, who I don't know if he was being kind to me or if he was so frustrated with my stupid questions that he was like, Paul, it's not that hard. The SEC says this is what a fund needs to look like.
Yeah.
And with current legal costs in 2010, he's like, it's probably about 70 grand for the first one you set up, and then maybe like 20 for each one you set up after that. And I was like, oh, well, that would have saved me a lot of trouble, you know? And then from there, it wasn't exactly easy. You still had to like set it up and do all these things, but he like made it accessible. And I think the easiest way I can kind of like maybe summarize or tie it back to what you just said is like, it totally makes sense. And it sort of feels like there's probably a finite number of what it costs to run through various iterations of this. And I think if there's any risk to it, you sort of alluded to this idea of like, if there's any risk to it, it's like, we all kind of anecdotally think there's probably data to support better outcomes. I think everybody would agree with that after a couple glasses of wine that like it probably helps. But really the only risk would be just figuring out what are the first N number of, pathways we're going to try to go investigate. Cause I'm sure these like analytics companies don't just want to like find the needle in the haystack. They have to be told what part of the haystack to look at. And that's what you're financing.
That's right. And think of it as the risk is not knowing. And another way to think about it is when it comes to you can develop contracts with either primary care practices that are taking risk and or with payers, right? And the risk in not finding out how you perform compared to peers and compared to the same general diagnosis, whether it's treated through PT or OT, whatever it is, as compared to other trajectories of care that are typically medically related. If you don't find that out, the practices and the payers will. They already are in some place. I mean, these things are already happening. So yes, it's a resource and it takes upfront money. But I guess part of it and part of why I get passionate about this message is I know this is happening, right? ACOs, practices, payers, they're stratifying data by diagnosis and looking at the trajectory. And they're saying, if we use this provider, we end up with this outcome. It's another, if you want to simplify it to just rates and you don't even want to get into contracting, if you look at, or if you don't, like you want to put that as the next step, but you want to start with, listen, we're not getting a good rate from this payer. if you had the data to demonstrate the difference between treatment in your clinic or your group of clinics compared to number one, my peers, and number two, a different trajectory for that patient within the totality of the health system, that's where you have negotiating power, right? Like, we want it because we want it. And I'm not sitting in those rooms between therapy, practices trying to contract with a payer. But you have leverage when you have objective data, the same data they would be looking at from their perspective.
Right.
And you know what I'm
Yeah.
saying?
Yeah,
Yeah.
yeah, I'm tracking, I think. So now, let's just armchair quarterback this. So
Yep.
let's say somebody goes out there and says, okay, here's 100 grand or whatever the number is. I don't know what these analytics companies charge, right? But they say, here's 100 grand, 500 grand, whatever. And we're going to run a couple different angles here to try to figure out if there's a defensible
Hmm.
sort of story here. Okay, so now I find one. Where do I take that? Is it actually opening the conversation with payers? Is it lobbying my state Congress? So now I've got, let's just say we
Hmm.
do find that. Where do we go
Yeah.
next?
You would generally start with the payers. I mean, my assumption is that Medicare is still the better payer and your commercial reinsurers are not. So it's the easiest, obviously, to directly contact private insurers. You certainly have to get in front of the right person. But if you're talking first about rates, you want to demonstrate the same thing as if you're getting into a specific type of like risk-based arrangement, whether it's your price per unit you want to say is higher value to them because for the payer you're saving them money over the long haul, right? And then when it comes to somebody like Medicare, you're going to generally you would go through an accountable care organization, so or a primary care practice taking some kind of risk and fee for service. So all this is publicly available. You can look up every provider in your area that's in a relationship, and most of the time, one of the high spend, high variability areas is orthopedics. And, you know, it's not like we take it for granted that we treat better than probably anyone in the health system. We treat better back pain, balance, headaches, shoulder pain, arthritis. You go down the laundry list. These practices at risk, they're not always thinking about that. They're not always
Yeah.
thinking about, well, if I do this, then this will be the result. Generally, they're thinking about other physicians. They're figuring out how to contract with other docs. So you have to bring this to them in order to get them to kind of see it
Yeah.
with the data, right?
Well, and anecdotally, I would think the data is there, right? I mean,
I absolutely do. That's why I feel so passionately about getting this message out there. It's such a missed opportunity.
I mean, again, for anybody that doesn't know already, like you and I don't have any business relationship. So it's like, I'm learning along this at the same time as everybody else. But, I walked into this conversation with you thinking like, okay, I got to figure out how to get a BAA in place with 100 different practice owners in our client base and figure out how to share data. But, you
Yep.
just made it way more accessible, which is,
Yep.
hey, you don't need consensus. You just need to figure out if you're willing to put the dollars behind it.
Right. There's a whole load of data vendors that would be able to do it tomorrow.
Yeah, because like anecdotally, it makes sense. Like here, and this is probably not the most articulate example, but just let me just say it out loud, and then you can either confirm or tell me I'm on the wrong path here. But like, I know we're talking about Medicare, and I'm not in that demographic yet. But just anecdotally here or directionally here, it's like I train for marathons all the time, and here in Virginia, we have direct access available, so I can go for up to 60 days without having a referral. And I'm sure I would think that the data would support the fact that people like me that take our aches and pains, our running injuries to a PT first, are probably less likely to do something catastrophic and require a total knee replacement at, Inova Health Systems of Virginia or something like that. And that's what we're talking about here, right? That's the example.
That's exactly what we're talking about. Yeah.
Yeah, I mean, it's like yeah, I mean, I think about my parents, they're in their 70s and they're in decent shape. Separate discussion about, they're getting older and they have some crazy ideas that they want to talk about all the time. But anyway, that being said, though, I remember when my dad had his his knee replacement, right? Like, here we go. They sent home care. I mean, the whole bill must have been like, I think when the EOB came in, it was probably like 70 grand all in for everything. And, and he's better for it. He can pick up the grandkids and have a good time and all that. But when you have conversations like this, you can't help but wonder, like, had the option to go, because direct access is relatively new here in Virginia. I think it's
Yeah.
only like 2 years old.
Oh,
But
wow.
but it makes you wonder, like, could he have had access to this at a local facility under his Medicare, under his private payer when he was younger, and maybe therapied his way out of needing that replacement, or at least put it off for a while. I mean, I don't know.
The public doesn't know it. That's the problem. The public doesn't think if I have pain, I call PT, and especially not the Medicare population. That's not generally how they think. So, again, going back to the theme of why we need to work with primary care, we need them to buy in and understand and truly believe that instead of when my patient calls or I see them because they make an appointment for something that can be managed by a PT, that I change my practice pattern from referring for imaging and a specialist to referring to PT. They hold the keys. And the big opportunity for therapists here is we are, no matter, even if you were to 50% increase reimbursement to PTs, OTs, et cetera, we are miles more affordable than specialty medical care. So there's all of that opportunity, both, for the therapy, PTs, OTs, STs, the therapy population, and for providers at risk. But this is the disconnect, is we don't know that this is not what physicians are thinking about. We are not top of mind, and they have long-standing patterns how they manage patients. I'll give you a great 2-second example. Back pain. Okay. My daughter's boyfriend, he's a football player in college. He called me. I was on a business trip, calls me panicked that he had severe low back pain after kicking the ball. Oh, I think I strained it. So I did 20-minute telehealth consult at the train station. Clearly a disc derangement. I mean, not a doubt in my mind. I had him, we went through a couple of things. Won't go through my whole PT eval on the phone with him. We did get him on prednisone because it was very acute, and that's a very safe medication. And that was, knowing him, I thought that would be the right thing. And please go get a PT eval, go see the trainer, have them send you to PT, blah, 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 blah. Okay. I saw him when he came home to visit me. I treated him. He's doing much better, but fragile, right? It's a disc herniation, and he's a kicker. And you can imagine, you're not a PT, but the PT is listening. No, he could easily reherniate. Anyway, he goes to see his primary care doc this weekend. This just happened. He comes home, he goes to see his primary care doc. His primary care, now this is 2 or 3 weeks post-injury, gives him a muscle relaxer and an x-ray. That's the totality of his treatment, primary care, okay? What can they do? We intuitively know this, but that primary care doc, he didn't think PT. He thought muscle relaxer. So he called me and said, I don't know, Dana, they said for me to take this muscle relaxer. And I said, well, not if it's going to make you very sleepy. It's not going to fix anything, and you're not going to be able to study. So what you need to do is lumbar stabilization exercises. Go work with the trainer if you can't get therapy organized, at least at school, and at least have them call me. I'm happy to direct them through a plan. But I mean, it's just a classic example. What do? Imaging and medication. They can't treat.
Right.
But you have to bring that to them, to the people paying and the people referring. Docs have practice patterns that they're loath to give up until they have a reason to do it.
It's so interesting. Like we've got 4 young kids, and my wife just was reaching back in the car to do something, tweaked her neck, and now it's been like 3 or 4 days. And I said, well, honey, why don't you just go to the doctor or find a PT or whatever? And anyway, she said something, and she's not even in this industry, right? She said something like, yeah, I'm definitely not going to a doctor. And I thought it was so interesting. She didn't even stop. She didn't say hey, I'm not going to a PT. She just cut me off when I said, why don't you go to a PT or a doctor? I was just trying to be helpful. She's like, well, I know for sure I'm not going to a doctor. And I was like, why? She's like, they're just going to tell me what I already know, that I should probably rest. And maybe depending on how it goes, they'll tell me to go get an x-ray or something like that. But she's like, I need somebody to fix it. And the PT side of it seems like they'll give me some exercises. So it's interesting. Like, that would be a perfect example. What you just described is a perfect example of what could have been solved sooner had the, I don't even know if direct access is available up there, but had that particular patient.
Luckily for him, I intervened. But this is the treatment protocol weeks after by primary care. They don't have, and we have to think of it this way too, I think. Physicians can do a couple of things. They can give you a medication, They can take a couple minutes to try to educate you. They can refer you to someone else. That's about it. Right? They don't have manual skills or anything that they do mechanically. There's exceptions. There's some osteopaths that do some therapy, but again, by and large, physicians are not doing things to correct mechanical dysfunctions, to work on balance or safety or gait training. They don't do that.
Well, they're not trained for that, right? It's like you know, and it's so interesting, and I don't mean to say this in some incendiary way, but listening to you talk about this topic, which again, you probably take for granted. You're probably like, oh my gosh, like you are like
No.
thinking, oh man, this doesn't even make sense. Why would anybody listen? But on the flip side, e- even on the sidelines of places like PPS, the proverbial boogeyman in terms of like the constant rate cuts was them, those people that are out of touch. It was somebody that didn't really have a persona. It was like this weird them that nobody really
Yeah.
could define. Whereas like what you're talking about is like, hey, look, the data tells a story, and you just and so it's like, hey, it's not. I guess what I'm trying to say is, I think the narrative mentally for a lot of the people in the industry, at least the ones I saw at PPS, is that like the quote unquote constant rate cuts and all that is led by somebody in some fancy suit somewhere just sticking it to the man. When in fact the opposite is true, and that is that because the PT industry as a whole does not advocate for itself, it it sort of doesn't have a say in the conversation.
Well, I'd argue they're not advocating for the things that are going to move any needles. And they're I don't want to be critical. It's more missing an opportunity to look at things from the perspective of those that can do something. Like if we stay in our own lane as an industry, as a therapy industry, remember, I only practice treating family and friends. I'm not like a treating, and I don't work in the policy space on behalf of therapy. But that gives me an edge, I think, in trying to bring this opportunity to therapists to say, you can solve a problem for the profession, for payers, and much better for patients. But you have to see the point of view from which those who make the decisions are coming from. What are they trying to fix and figure out? What are their stressors? It's not enough money. If we're going to fix something, where is it coming from? And honestly, leave the conversion factor fixes up to the physicians and the specialists. There's so many strong lobbies that they have. Give them the conversion factor issue. But Congress is thinking a lot about, for anybody interested, and I can send you the links if you want to put in the show notes. Senate Finance Committee has a macro working group. They have a primary care hybrid payment working draft. Then the heads of Senate Finance, Wyden and Crapo, they have a chronic care 2.0 act, essentially also calling for hybrid payments for primary care. At least understanding what it is that the most powerful committee in Congress in healthcare, by far most powerful, what are they thinking about? If this is what's on their mind, they're trying to figure out how to fix these issues. And we have to figure out where we fit in that place, because they're not just going to drop that. It takes a long time to make these fixes. So, right, like, why are we wasting our time on conversion
Yeah,
factor? We can
yeah,
second it, but that's not where I'd be arguing for things like, practitioner status. Why are we not on the practitioner list? And we're suppliers. That's the perception stuff where they can use that as tools when we have other discussions.
right,
Now
right,
you got
right.
me all passionate talking.
No, I love it because I think it's interesting because like okay, this is not going to come out the right way until I like blurt this out over the
Uh-oh.
course of 30 seconds, I suppose. But to simplify this, I would say when I think of like the pyramid of this industry, right? I think what you're talking about is a very articulate way to kind of make the case essentially from the top down. Like, this is how you get, if you show the data and if you sit at the tables and you advocate for yourselves and all that, you can take this top down approach to kind of hit massive wins. I mean, any small win at that level turns into a massive win for the entire industry. So it's a very, very important. And then people like me sort of look at it from the bottom up where it's like, huh, what would happen hypothetically? Like obviously one path is somebody, like me from the outside, not PT, not whatever, like
Mm-hmm.
somebody from the outside kind of almost takes like a venture capital approach to this and says, let's go
Mm-hmm.
fund 10 of these VDRC studies, knowing that if even one hits, it'll be venture style returns, the 100x return as we figure out how to then arm that person top down.
That's
But
right.
simultaneously, it makes me think like, hey, who's running the ad campaigns to educate these people or these patients in these direct access states that this is an option? Like my dad didn't even know it was an option. He thought he's supposed to go through Kaiser, his healthcare provider at the time. He's like, I don't know. I just thought I had to go to Kaiser. No, never mind the fact that there's a massive PT chain. I don't want to like say their name, but like there's a massive PT chain with a massive facility right outside his neighborhood. He could have just rolled in there for 60 days, and maybe have gotten a better outcome that didn't require the surgery a couple of years later. Who knows?
I think we need docs to be our surrogates. I really do. We can put out, I mean, APT has been doing that, right? Campaigns. Direct access is not a word that resonates with the public really well, right? It's not like people say value-based care doesn't resonate with some in the public, and I understand why. Direct access is something that totally makes sense to us, but my grandmother, she's not going to know what it means, right?
Well,
So,
it's
yeah.
interesting. I'm sorry, I cut you off. Keep going.
No,
I'm sorry.
no, I was just going to say that people think of their doc as the person I go to when I have pain or concern or worry or whatever. I go to my doc. We want the first thing doctors to think of, especially in primary care and especially as they're being funded more and they have more power and control over their patients. We want them to think, it's better for my practice and continuity of care. It's better for the patient. It's better for total cost of care. It's better for my risk arrangement to send that patient to my very engaged therapy clinic that I work closely with, or see the therapist that's embedded in the practice and have them work with the outside provider. You want that to be their first thought. That's what's going to build the momentum to build up this profession, right? It's the profession that needs a lift. Yeah.
This is probably like such a amateur
No, no.
observation or a question or whatever. Observation veiled as a question. I don't know, but it's like I wear glasses. You wear glasses, and I don't remember when I was explicitly told that I could get my glasses from anywhere. If I had to think about it right here on the fly with you,
Yeah.
I just kind of know that I can get my glasses from anywhere and I can just like submit the form to my insurance. And even though it's an antiquated process, I get reimbursed for it. But I don't know where that started. And then over time, like now I just buy everything from Warby Parker, not
Yeah.
because it's like the best prices or whatever, but because at the end of the checkout flow, it just says, hey, by the way, who's your insurance? And then as part of the receipt, you get a package that you just print out, throw in the mail, and it does it. I'm like, oh, this is so good. But like it's so interesting. Like I wonder, and this is probably a bigger question for somebody that with some research on this, but I wonder if there were like weird lobbying things or marketing things that the optometrists did 10, 20, 30 years ago that sort of like set or paved the way for that. Like here in
They
Virginia,
did. And podiatrists too. This just came up on a conversation very recently, and I can't place it, but those professions went through a concerted effort to build their stature and call themselves doctors. And doctors of optometry, I mean, I don't, in my mind, I don't think of them as equal to ophthalmologists, but
right?
the population, most of them don't know the difference, right?
100%.
And
Yeah.
they're practitioners. I mean, they have an elevated status, but they did I will call this ground up work. They did professional ground up work with the right stakeholders. And I would argue for us, it's understanding what everyone else, we think about what we think about. What does everybody else think about that controls the dollars and controls the policy? Those are often the same. What are they thinking about? What's in their mind? And how do we tap into that? And like the data's out there. I would argue we're not using it. And because part of it is, I don't think we know how other provider types are using it. They've broken the ground. They've figured it all out already. We just have to look at it from the lens of the things that therapists usually treat. And there's a broad spectrum between pain and weakness and balance. I mean, there's a lot that we can prove the value of to a payer and a provider at risk.
I love it. I love it. All right. Now I want to be respectful of your time, but I'm going to open up one more can of worms here
Sure.
because you flagged an article for us to talk about, or maybe you actually flagged for me to look at, and now we're going to talk about it anyway.
I can't remember.
uh, and I think our conversation has kind of set this up pretty well, where we talk about this idea that, like, well, anyway, let me just cut to the chase. So you sent me an article from Becker's Orthopedic Review, and it's sort of a 1 month, it's sort of a recap of the first month post rollout of United Healthcare's prior authorization requirements, particularly for PT, OT, and speech. And we'll link to this in the show notes, because you flagged it. But in it, you've got people quoted and talking about how bad the rollout was and how bumpy it was and stuff like that. But just to tie it back to what we're talking about here, it seems to me like this, and I apologize, I should have sent you the article just so you could look at it. But
I sent
just
it to
reading
you.
the article here or scanning it here on the other screen, it's like, it kind of makes sense. It's like, okay, and I'm going to say this like a second grader here, so everybody can make fun of me. I'm sure the idea of requiring prior authorizations came from a good place. Like, I'm sure there was a reason. Like, let's just start from like a positive viewpoint here. Like, I think it's easy for people to say, oh, look at the dark pattern here. Everybody's out to screw everybody. But let's start from the premise of some team at UHC thought, there's probably a good reason for us to do prior authorization for PTOT and speech. Okay, whatever that might be. And now a month later, it in this article, they quote it as a disastrous rollout. And they go on to say things like, you go to the portal to opt in, the systems are down. The small mom and pop practices are the most adversely affected because they don't have but it even goes on to talk about, like, hey, even when you call the people at UHC, they don't understand PTOT and speech, and they're sort of gently nudging people right back to primary care because that's all they know.
Mm-hmm.
And this is maybe a statement more than a question, but I thought it was interesting to tie this article back to kind of what you're talking about here, is that, like, this is what it means to educate not only the legislators, but everybody through the value chain. Because if the first person that actually picks up the phone at your insurance provider doesn't realize that PT is direct access and could possibly solve some of these issues, they're going to do what they know best, which is, who's your primary care physician? We should definitely send you over there.
Yeah, I'm going to make a couple notes so I don't forget as we're talking about it. So first on education, because you brought up who we have to educate. Okay. So most people don't get this right. And so just to clarify for anybody listening, what lobbyists do almost in a big part of their job is educating those who are deciding on what legislation to write, how to write it, right? Lobbyists do a lot of education. They build relationships and they educate. So therapists should be thinking about, what should we be educating them on that they don't understand? And again, it's removing your own self, your own profession a bit and looking at the bigger picture so you can understand what it is they do and don't know and what it is they do and don't care about, right? So let's start with that. First of all, that lobbyists primarily are doing education. And then the other, so on prior auth. Prior auth is a topic that I think causes the most controversy when I get into conversations on LinkedIn about it. And it is coming from a place of, if therapists understood this concept a little bit better, they could advocate for the change that they want. But I think that the perspective that therapists have, and there's a lot of truth behind some of what they're saying, is they're making it too difficult for me to see my patients. These people need this care. I don't have to deal with this in fee for service. Why do I have to deal with it in Medicare? Let's go back to why we have prior auth, because it's crucial to understanding kind of what can and can't change. So in fee for service Medicare, right, which is the best payer in a number of settings, and one of them is generally outpatient therapy, there's never anyone questioning, like, nobody, unless you're audited, nobody's looking at what you're billing, right? You have to and should be absolutely compliant in everything you document, and everything you bill should be, as I'm assuming everyone is, on the up and up and up. But no one is looking at whether or not, unless you're audited, whether or not that's actually happening. But the problem on the other side is that fee for service has allowed, and I'm totally not singling out therapists, it's allowed providers of any and all kind to just do what they want rather than always what is medically necessary. And there is no control in fee for service over what providers do. I know the backlash is, well, it's nobody's business. The provider knows best. But what we know when we look at the data is that doing more care does not, in a lot of circumstances, translate to better outcomes. So it's good to know what does and doesn't, right? I will parallel this because I've talked to therapists about this in the skilled nursing world all the time, right? And the American Healthcare Association, which is the Association for Skilled Nursing Facilities, they have had the exact same rhetoric, and it's been very successful. Medicare Advantage is telling us how long we can see our patients. They're limiting who can come. They're limiting how long they're here. The problem with the argument is that when studies have been done, not that there's been a whole lot, the average length of stay is ballpark 14 days in SNFs and for Medicare Advantage. And it's like I think at this point, it's like 32 days for fee for service at about double the per day rate in fee for service. And there's nothing to say that those outcomes are any better, right? And so you can have the argument that we shouldn't have prior auth, but it has to link to outcomes. Otherwise, it's just, right, it's blowing smoke. We have to be able, if we're going to say they shouldn't prior auth at all, then prove that what we're doing is worth the care that we're giving, right? Like it's for a purpose. Every visit is medically necessary. It's a big hoop to jump through, but it's why prior auth exists. Medicare Advantage, they can't control costs if they do what we do in fee for service, which is providers do whatever they want. There's a balance there. The article with these big delays in service, well, that's not good, right? We don't want delays in care. We want patients to be able to get their evaluation and get their treatment as they should get it. But that's what separates anything that's managed versus just fee for service. Fee for service has huge variability, and variability is a problem. And where it's good for therapists is one of the worst places of variability is in orthopedics. And we can capitalize as a profession on that variability in medical spend in orthopedics by demonstrating a vastly different set of outcomes and cost for a number of different diagnoses, conditions, right?
Yeah.
Does that sort of, do you have questions? Because
I
don't know
think
if I got
this is
that
going to be the
across.
next can of worms we really talk about here, on the next episode too. I think it's so the best way I could maybe summarize this is to say, yes, I have questions. And I think other people are gonna have questions too. I think that this is one of those things where you took what seems like a very simple topic. I think most people look at the concept of prior authorizations as a black versus white issue. Like I probably shouldn't have said it that way, but it's a black and white versus issue, like right versus wrong, that sort of thing. But you sort of lay out the case for, hey, look, it's a little more complicated than that. And here's why. And I think this is the stuff where you probably, again, you've been doing this for so long and you're looking at it through the lens of, you were a PT as well. And it's like, let's talk about this more openly to people and then like show them there's a path. Like, it's not like the system is rigged. It's like, no. It's just that people with, the PT kind of OT designations just are not involved in these conversations. And the more you understand, I mean, just as a summary, what I always tell like people on the venture side of my efforts is I say like, look, the more that people just take 30 minutes to understand how the business of money works, the better equipped you are to understand why people say no sometimes to investing versus yes. And it's not at all what Shark Tank makes you think. Shark Tank makes you think like if you just say the right combination of words to Mark Cuban, he's going to write you a big check.
Right.
When it's a little bit more nuanced and actually easier if you really understand where the money comes from. And it's kind of like what you're talking about here is that like prior authorization is a little bit more than just a right versus wrong issue. It's
easy to do it wrong. All right, Paul. So that's an important clarification. It's really easy to do it wrong, not have the right people reviewing charts. And I'm going to I don't want to create any anger towards me in the therapy community. I am pro accountability for the dollars we spend in the care we give. I'm not pro one payer over another. And that's holistically me, independently as a treating physical therapist. I treat a little bit now, but I treated for a very long time. as part of a health system that is bleeding money because of a lot of different reasons, but there's a big chunk of waste. And none of us who are in the provider community like to think what I do is wasteful. But we have to figure out what's medically necessary and what is not. And I go back, I used to say this to the health system when we were first talking about accountable care, and they're trying to understand it. It's just wants versus needs, wants versus needs. What's medically necessary, and what do we want to do, and what do we want to help our patients with? And that's being solved for. So it's not like, I don't want to sound like I'm preaching to therapists. I want them to see where it comes from so that they can prepare and think of other ways to strategize around this for the benefit of their own businesses, of the profession. There's all kinds of, I've been listening to a lot of therapy podcasts since coming onto yours and kind of starting this up. And there's so much amazing innovation in the therapy space that needs to continue and is really fantastic and awesome on so many levels.
Yeah.
What we're not thinking about, at least I haven't heard too much of, is how do we help manage the health of the country, right? Not just, we have to worry about our own bottom line. That's all this advocacy we're talking about. But how do we think of ourselves as helping to improve the health of the population of this country if we have the right funding to do it? We can't just do it by cash-based pay, right? I understand why we do. I totally understand why therapists do it, but it can't be the only solution. And our integration into the larger healthcare system, into the care continuum, mainstreaming us into regular medical care, right? Us being thought of as doctors, just like podiatrists and optometrists, that's how we make it. That's how we make the impact on the profession that we wanted to. We haven't been paid fairly for our work, right? So there's a number of different issues here, and seeing them for what they are separately and not trying to mash them together into everything is bad and, we're going to fix it by doing this one thing. It's fixable. We can make great progress, but we have to know what the issues are first and what the truth is, right? The truth will set you free. The truth is where we're going to build from.
Thanks for listening to another episode of Strata Stories. Strata PT is a single EMR platform and revenue cycle management service for physical, occupational, and speech therapy practices that helps you achieve a 99.99% reimbursement rate. If you'd like to learn more about Strata PT and see how our EMR and RCM works, head over to stratapt.com to book a demo.